Medical Specialists Associates, making medical education more accessible.
Well, thank you, everyone who is listening to this podcast. My name is Christopher Voscopoulos, and I'm president of Medical Specialists Associates. And this, again, is one of our podcast topics, and we're going to be covering today hyponatremia. I'm joined again by one of my colleagues, Nazir Habib, who's really an expert in this area. And really one of the amazing things that I like to chat with Dr. Habib about on this topic is that so many of us think that we know hyponatremia so well because we see it so often, but Dr. Habib really has this uncanny ability to talk about some of the small details that you might have really missed all these years in treating the entity, and I always learn something from him. So with that, I want to say, Dr. Habib, thanks for joining us again tonight. I'm going to start off with our first question, and that is that to my experience, when we're treating hyponatremia, we really break it up into the presentation of the patient into symptomatic and non-symptomatic. Can you tell me why that is, and what do these presentations look like?
Thank you, Chris, for this introduction. And I must say that hyponatremia has become one of my favorite topics to talk about because it is so common and it is so frequently under-recognized as a very, very significant problem and causing critical illness. And, we can talk about levels, but I think that your question about symptoms is a very good one because I think it's often under-recognized that the patient has symptoms early on whenever the sodium is 128, 130, which we would pass off as being insignificant. Actually, it turns out to be very significant because the mortality increases 14-fold when the sodium is less than 128. So I generally ask for early symptoms, which my favorite questions are you having nausea, vomiting, headaches, muscle fatigue, cramps, difficulty remembering things? And one of the most important early symptoms is ataxia or falling tendencies. So split your symptoms into these questions. Those are early symptoms. When the sodium falls rapidly down to 120, 122, or less than 120, the patient may present with seizures, altered level of consciousness, delirium, go into a coma, and they may even present with focal neurological symptoms. I've seen hyponatremia present as a stroke. And then sometimes the patients can present with non-cardiac pulmonary edema, what's called the IS-REF syndrome. So watch out for pulmonary edema, which is due to neurogenic swelling of the brain that causes non-cardiac pulmonary edema.
I think this is so important. When I first thought about symptomatic versus non-symptomatic, I would think of the big three. Is the patient having neurogenic pulmonary edema? Is the patient having seizures? Is the patient having severe delirium, altered mental status, right? But here you really dial into some of the subtleties. Is the patient forgetful? Are they having a hard time, having their normal cognition? So these things could be more subtle. And I think that's where people, are missing very important diagnoses. And it's really important for you to mention that. So now can you tell me, why is it important for us to break these entities up into symptomatic versus non-symptomatic from a treatment standpoint?
Yeah, I think that it's very important to recognize the early symptoms because I find that, physicians tend to wait to treat with hypertonic saline or jump onto the treatment wagon until the patient is much sicker or the sodium is much lower. And the studies have shown that the mortality and morbidity shoots up to about 60%. And there's a very nice review article on encephalopathy from hyponatremia, which I'll post on our website from Critical Care Medicine, October 2017. It's a fantastic review. I recommend everybody should read that.
And so when we're breaking down really the entity into symptomatic versus non-symptomatic, we're really driving home that we treat symptomatic with hypertonic saline. And, we often will start with, say, 100 cc's of 3% to see if that, reverses the course and has the person come back to their normal baseline mental status. And we might repeat that, one additional time. And usually around, the first or second time, gets the patient back to baseline. But as critical care doctors, you can tell me, if you've seen this as well, I'm sure you have, countless times. It seems like some of our hospitals colleagues are reluctant to treat with hypertonic saline for a fear of, creating osmotic demyelination syndrome, but that's not really the case, is it?
Absolutely not. I think that this fear of osmotic demyelination has overblown and caused paralysis for a lot of our colleagues because they don't want to give hypertonic saline. And this is clearly described in the New England Journal of Medicine and in Critical Care Medicine that one should not delay treatment with boluses of hypertonic saline, not infusions, but small boluses, 2 cc's per kilogram, will only increase the sodium by 2. This is a very simple formula. 3% normal saline given peripherally will only increase your serum sodium by 2. So you're quite safe in avoiding that territory of osmotic demyelination from giving boluses of hypertonic saline. And I would recommend that as soon as you have signs of hyponatremic encephalopathy, symptomatically, not physically, but symptomatically, you will notice a huge improvement in the patient's mental status. The cognitive function that you mentioned earlier will improve with 1 or 2 boluses, and the patient will have better appetite, their headache, their nausea, vomiting, their muscle strength improves dramatically within an hour.
That's amazing. When we talk about, the entity of osmotic demyelination, we think about overcorrection or correction too quick. Can you just comment upon, how fast can we correct that would be safe?
Yes, I think so. I think, the symptoms of hyponatremia often depend on how quickly the sodium is dropped and how acutely, right? So generally, people worry, is this acute hyponatremia or chronic hyponatremia? They recommend that these guidelines or partitions are very artificial. Just treat everybody with hyponatremia like they're chronic, okay? And treat them early when they're starting to have early signs and symptoms. And if you give them hypertonic saline, then you want to recheck their sodium an hour or 2 hours later because you don't want to overcorrect. So what do we mean by overcorrection? Generally, the guideline is that in the first 24 hours, the maximum you want to correct the serum sodium is by 8. In the 6 hours, you want to correct it by 4 to 6 milliequivalents. Okay, but again, if the patient is seizing at a serum sodium of 110, you have to give enough hypotonic saline to stop them from seizing. So you might bring that sodium up to 118 just to stop them from seizing or wake them up. So it depends how sick the patient is to some degree as well.
And in that particular case, if someone came in with a sodium of 110 and you had to get them up to 118 to have them stop seizing, would you then keep them at that number for 24 hours because you corrected by 8, so quickly, or is there some room to go up a little higher?
No, I think that, I'm looking for improvement in their neurological status. So if you're stop seizing at 116 or 118, I would leave them at that, and probably not go above 120 for the first 24 hours. Right. And it's very important to understand, it's not the hypertonic saline that's overcorrecting the patient because it's a calculation, physiological calculation. When you see overcorrection, it's because the patient is diuresing themselves. Okay, there's an auto aquaresis that goes on in certain patients, and we can discuss which patients are going to pee too much urine, and that will shoot the sodium up.
So let's
what should you do?
That. But because that is something that we do see when we're correcting the sodium, the patient could start, dumping urine, and that's when we have to think about, using treatments, of course, such as DDAVP, and then using free water to keep that sodium, within the range that we want. Can you talk about that a little bit? Why does someone dump the urine, and how do you go about treating it?
Yeah, so this is very, very important. There are a certain subset of patients that you have to, and your ICU nurses should be very, very cognizant of the patients that are going to dump a liter or two, because that will shoot up the sodium based on their on their actual body weight, how quickly it'll go up. So which patients are going to have this excessive water diuresis? Patients on hydrochlorothiazide, beer drinkers, beer potomania, compulsive water drinkers. Okay, so there are like 3 or 4 types of patients who are on DDAVP and you stop suddenly will pee a liter or 2 in an hour. Okay, if they pee out a liter or 2 in 1 hour or 2 hours, their serum sodium will shoot up. And it's not because you gave hypertonic saline. So in order to bring the sodium back down, you have to give DDAVP. Some authorities or some centers are actually using DDAVP in beer potomania and hydrochlorothiazide and compulsive water drinkers before you give the hypertonic saline or with the hypertonic saline to prevent this water dumping.
That's very interesting to get ahead and to know. And so, that leads me into my last question then is, very commonly what I do is I bring our ICU pharmacist into the picture early to review medications as etiologies to why the patient might be having hyponatremia. And you mentioned one really important one, which is hydrochlorothiazide, where people will concomitantly treat with DDAVP. But are there other medications that people, should really be looking for as well?
Yeah, I think that in young people, I often worry about ecstasy. Because that can cause water intoxication very quickly and severe hyponatremia and seizures, and they can dump water. And I always take a very, very good alcohol history, especially beer. So we see a lot of beer potomania because sometimes they also drink a lot of water. The number one medication in the world today that causes SIADH are actually SSRIs. So I always look for SSRIs. Usually in the first 2 weeks of starting an SSRI, the patient drinks a lot of water, they will present with severe hyponatremia. There's a list of medications that is on our website in my presentation on hyponatremia. So go through that checklist of all the medications, but SSRIs, beer, and hydrochlorothiazide.
And actually, before we close here, I wanted to just mention that we did talk about important things such as someone who comes in symptomatic and the use of hypertonic saline, which, we wanted to drive home that point because it's so often delayed. And by the time that we get consulted, treatment could have started sooner. And so that's why we want to bring home that point. But I also want to mention, though, that if we have someone who's non-symptomatic at the time, just simple fluid restriction from the get-go is the initial treatment. All too often, and I'm sure you see it too, individuals will be more commonly maybe treating with normal saline or something like this when they really should be fluid restricting instead. Could you just touch on that before we close?
Yes, absolutely. I see normal saline being given frequently, especially in the ER, to all hyponatremic patients. And this is very dangerous, especially if the patient has SIADH, because you're actually causing a desalination. The patient will dump the salt from the normal saline into the urine immediately. If you check a urine sodium, it's 80. Well, they're going to dump the sodium in the urine, but they're going to retain the water from the liter of saline. So you will find that if the serum sodium drops with normal saline, that pretty much clinches the diagnosis of SIADH, right? So avoid normal saline, send a urine sodium and a urine osmolarity. You can go through the differential of hyponatremia, but pretty much you cannot hurt a patient by giving hypertonic saline. And you can do it through a peripheral IV. I see a lot of protocols that say you need a central line for 3% saline, and that is just not true. So hospitals need to get rid of that standard of using central line, because that's just delaying stuff.
Well, Dr. Nazir, I think Dr. Habib, I think we're going to, close here. I just want to say, I've been doing this for 12 years full time, and every time I talk to you about a topic, I feel as if I learned something new. And that's so I really appreciate you sharing, your wisdom. And I look forward to chatting with you next week on another topic. So thank you so much for your time.
Thank you. Thank you, Chris.
For more information, please visit our website at www.med-specialists.net. You can also find us on YouTube as Medical Specialists Associates. Thanks for listening.